Most of us know that thrombus is the Achilles heel of the cardiologist. There are a lot of editorials which say that thrombus is the unconquered, animal, which most of us have not been able to conquer over a period of years. So whenever there is a thrombus, most of us are at a puzzle as to what is to be done, because no reflow phenomena which occurs as a consequence of thrombus, thromboembolism, pushes up the mortality so much that literally one has to deal with this problem. So I really congratulate this new technology which has come up, which is very useful to treat thrombus containing lesions. Now this is a micro mesh for embolic protection over a coronary stent. So essentially it's a thrombus entrapment device with a stent. And what are the concerns that we had? First time when I saw, and I used for 1 or 2 patients, then I thought, what is the downside of this technology? So the downside of the technology was, I'm using a bare metal stent with a mesh in acute MI, so the restenosis rate, is it going to be higher? That's my concern number 1. Concern number 2 was because of the mesh, whether I'm going to compromise the side branch occlusion. Number 3, because there's a mesh and because the polymer, as we know, increases the thrombosis rate, I was concerned whether there's going to be more stent thrombosis. And the 4th question which I had in my mind was whether I should use aspiration or not. So these are my concerns which I addressed. And then going through the data, I thought that most of these concerns are not very great significance. This new technology, they have already thought of these concerns and made this device available, which is very useful. Now, the priority in a primary PCI is to open the occluded vessel, maintain good LV function post-procedure. Restenosis, yes, is a question, and whether to use DES itself. Today we saw presentations which said that unless DES is mandatory, where the vessel size is less than 3, or whether if somebody is a long-standing diabetes, then the bare metal stent does equally well. So these are certain situations where bare metal stent will do well, and then but it will first take care of your problem on the cath lab table, that the patient who is already borderline hypotensive, he will not further deteriorate with the no reflow phenomena. Most of us have seen that once you cross with the balloon and open the vessel when you're doing primary angioplasties, suddenly there is a drop in the pressures, the patient deteriorates for some time, and then you have to tackle that with dopamine, dobutamine and phenyl. Now that's the time where embolism has occurred. That is going to block the peripheral coronary circulation, that is going to cause no reflow and also cause a CPK bump. The higher the CPK bump, the more the mortality. So this is what we are preventing in the acute phase. Now you know that this is what is the data about no reflow. Most of us have dealt with this problem and have faced this problem. Now infarct size is 15% versus 8%, and 5-year mortality jumps to almost 2 times when there is a no reflow phenomena because of the thromboembolism. So this is what we are concerned about. Acute MI is all about thrombus. The more efficiently you manage the thrombus, or more safely you manage the thrombus, the better result that you will get. Lesion in acute MI is very easy to cross. You almost achieve a 95 to 100% result. But your main problem is the thrombus, which you have to address. And then this is a very good technology to address that problem. Now, long-term follow-up data after DES versus BMS, I don't have to say, we already had a session in the morning that unless somebody is a diabetic or the vessel size is 2.75 or less, if the vessel size is big, the lesion is discrete. If somebody is a non-diabetic, it doesn't make any sense to put in a DES. In fact, you may have a negative or a positive remodeling at a later time. Now, what is the 2 years TVR in ST elevation MI patients with MGOT versus DES, this is versus BM. Now, this is from the London Chest Hospital. They have done studies, and what they found that when they used an MGOT, the TVR rate at 2 years is 6% versus 5.8% with the DES versus 8.7% with the BMS. So there is almost a significant, there is not much of increase of TVR, though it's a bare metal stent. Now, why is it so? Now, when you deploy a stent, the stent goes into the vessel wall and it causes injury at the vessel endothelium. Now, this endothelial injury provokes the hyperplasia and the migration of smooth muscle cells. But here what you see is the net is there. Sorry about that. So there is a net which is above the stent. Now this would prevent the metal from coming in contact and causing injury to the endothelium. Now that is what possibly prevents or causes a lesser TVR. Now this is a polyethylene tetraphthalate fiber which is 20 micrometer thick. It's a single fiber circular knitting. The pore size is huge, 150 to 180 micrometers. So this the concerns about side branch occlusion are unfounded, and even in a bifurcation anatomy and also for a stent thrombosis at 2 years data, what they found that this single fiber, the stent thrombosis rate is 1.1% versus the 3.5%, 3.7% the taxes. So BMS with express BMS was 3.6%. So even your late stent thrombosis is not higher with this stent. Now the other question which I had in my mind was whether I should use a thrombus aspiration, because recently thrombus aspiration has come into vogue following the TAPA study. Now what has been found is that you are pushing a high French catheter across a lesion. Sure, you are aspirating from thrombus, but at the first instance you are pushing a high French catheter across the thrombus. That itself causes a distal embolization. Now this is a histopathological analysis of thrombi from the aspiration. It shows a predominance of platelets, and a lot of times the thrombus is not seen, and a lot of times the thrombus there is no aspirate. So in spite of using an aspiration catheter, then you may not get any thrombus. So then this is where we stand as of present with the technology of thrombus aspiration. Now this was the magical trial, MGuard ST elevation MI study, where they no prior aspiration versus prior aspiration. What has happened? The blue is one where there is no prior aspiration, and the red is one where they use aspiration catheter. Now TIMI3 flow is actually higher when they have not used any aspiration. Myocardial blush grade is same. Complete ST resolution is much higher when they have not used an aspiration catheter, and TIMI3 and myocardial blush grade U3 is much higher. So there is no real sense in using an aspiration catheter and then trying to put the mesh around that. You push the horse out of the barn, and once the horse has bolted, there is no point in closing the door. So what you do is with a low profile stent, you go across the lesion and entrap that debris against the wall. So there is no embolization. Conclusion, this is a new technology combining embolic protection device on a stent platform. The first data for MGuard in ST elevation MI derives from multinational and multi-center small trials. Very high acute perfusion results. This is exciting technology on the horizon. The myocardial blush grade is 83%, TIMI3 flow is 95%, complete ST resolution is 79%, and good clinical results, and MACE at 2 years is 7.9 and TVR is 3.4. So this technology gives in ST elevation MI and thrombus management low mortality and morbidity, and it gives good acute positive results. With today's practice, we can actually achieve a perfect perfusion in only 50% of the patients. But with this technology, we can achieve a much higher TIMI3 flow and a much better myocardial blush grade. Restenosis, which is a concern, it can be treated, but no reflow, as we know, pushes your acute mortality and also the long-term mortality of these patients. So distal embolization has no effective rescue solution, and this technology today in our hand gives a niche for treating thrombus-containing lesions. Thank you very much.